Good afternoon, everybody. I hope everyone is well and safe. It is with a great pleasure that I received the invitation from Dental Summit to speak about this subject that is of interest to me. So I thank the organization for the opportunity. Our talk today is entitled New Trends in Endodontics, from Diagnosis to Treatment. My name is Taia Rezende. I speak to you from Brazil, where I live and work. I am currently a professor and researcher at the Catholic University of Brasilia, where I work in the dentistry course and in the post-graduation program in genomic science and biotechnology. Our speech will have 3 moments where we will discuss the state of art, where we are, and where are we going. The dental pulp is composed of connective tissue, rich in blood and lymphatic vessels, myelinated and unmyelinated nerves, and indifferentiation mesenchymal cells. Like other connective tissues, when injured, it can respond in a regressive or inflammatory way, depending on the intensity and duration of the causative agent. Dental care is the most common cause of the need for endodontic treatment. The microorganisms in the oral cavity break the enamel and dentin layers, reaching the dental pulp. From this moment on, an immune inflammatory pulp response tries to contain the microbial progression. The pulp inflammatory response generates edema and releases inflammatory mediators, including neuropeptides, which culminates in severe pain in cases of irreversible pulpitis. In this clinical situation, the infection is more located in the superficial pulp. However, the pulp tissue has already undergone changes that do not allow it to return to normal. As the immunoinflammatory response advances in the apical direction, a microbial progression is also observed. Thus, pulpectomy followed by chemical-mechanical preparation of the root canal is necessary. When the pulp defenses are overcome, pulp necrosis is installed, and in this way, microbial progression reaches the entire space of the root system, in addition to periradicular regions. The periradicular regions advances in its immunoinflammatory response process with the release of inflammatory mediators that interact with bone cells, leading to the occurrence of periradicular bone resorption. Thus, in the face of illness, the whole of the endodontist is to establish health. And the best way to reduce root canal contamination is to carefully cleaning and shaping the necrotic canal, concepts defended by Schilder since 1974. Knowing the origin of pulp tissue and how changes in this tissue occur, we are moving towards understanding what we know about endodontic treatment. About the clinical diagnosis, it is already known that the response triggered in irreversible pulpitis comprises an inflammatory immune response with involvement of the innate and adaptive pulp immune response. This process includes the release of inflammatory mediators which due to the drainage comprised by the pulp anatomy often leads to the ecstasy of this tissue, leading to pulp necrosis. This failure of pulp tissue allows the progression of contamination to the periradicular area. In the periradicular space, inflammatory mediators start to act on the periradicular bone structure. In this environment, the ligand of the nuclear factor kappa beta activator receptor, the RANKL, produced by osteoblasts and lymphocytes, binds to the RANK receptor present in pre-osteoclast cells, initiating the differentiation of osteoclasts and the resorptive process. The established periradicular lesions are defense mechanisms against the spread of the infection process in other regions of the organism. Another important fact related to periradicular lesions, especially in cases of failure after endodontic treatment, is that the maintenance of the infection condition may be related to the presence of extra-radicular biofilm. In this paper, patients with post-endodontic treatment failures, in which the failure sequence involved initial endodontic treatment, retreatment, and periodontic surgery, were selected. After all this series of unsuccessful treatments, part or all root surfaces were analyzed by scanning electron microscopy. The establishment of the mature biofilm in the periradicular region was observed, and the case indicated for extraction, the extension of this biofilm was in almost the entire root surface, demonstrating the need for use of more effective strategies to remove extraradicular biofilm. Another aspect that has been widely reported in the endodontic context is the relationship between patient's systemic condition and the PULP periradicular condition. Diaz et al. 2016 observed that the expression of cytokines in the interstitial periapical fluid of patients with a periradicular lesion is different from the expression of cytokine present in the drainage sites of patients with severe odontogenic infection. Patients with odontogenic infection exhibited an extraordinary profile of pro-inflammatory cytokines and an unaltered expression of regulatory mediators. In another study, Samuel et al. 2017 observed in rat models that the presence of multiple periradicular lesions increased the number of leukocytes, lymphocytes, and the tumor necrosis factor alpha present in the animal's peripheral blood compared to animals without periapical lesions or with only one periapical lesion, demonstrating that local changes in the periapex can generate systemic changes. PULP periradicular conditions have been shown to affect the systemic balance of patients with preeclampsia, coronary artery disease, hypertension, liver cirrhosis, chronic kidney disease, and diabetes. On the other hand, different systemic conditions of patients can also affect the PULP periradicular response. As an example, we can mention the diabetes condition. It has been reported that patients with decompensated diabetes have altered in the periradicular PULP circulation in addition to difficulties to healing and periradicular repair. Furthermore, during the PULP periapical immune response process, glycemic changes can promote changes in the rank-alpha, TNF-alpha, IL-10, IL-4, and IL-6 cytokines, further interfering in the patient's local response. Thus, as systemic condition can affect PULP and periradicular response, the effect of endodontic treatment on these patients will also be different and needs to be analyzed during the planning of the clinical case. And what about strategies and or tools for endodontic treatment? What is new? During endodontic treatment, image tests are essential for the study of internal anatomy and definition of strategies to be used during treatment. Thus, better images were acquired with the development of digital sensors and the use of software to analyze these images. Thus, the greater popularization and quality of three-dimensional tomography analysis allows the identification of clinically and radiographically unidentified canals, extensions of resorptions, and periapical lesions, among other indications. This improvement in the image test, together with the association of the image with 3D printing, allowed the obtaining of three-dimensional models, permitting the dentist to manipulate the region to be operated on prior to the surgical procedure. In this way, a digital scenario emerged for the endodontics, and the digital workflow allowed for the obtaining of endodontic guides to assist clinical planning of treatments. Thus, The use of endodontic guide allows greater predictability in assessing obliterated canals where the risk of perforation is high. These guides are designed to directly drill to the root canal in a direction and precise way in software, and after the printed guide, it is used to make this path clinically. With the great success of the use of endodontic guides in obliterated canals, its use in endodontics has expanded, and endodontic guides can also be helpful in periodontic surgery. Published surgical guides report assistance during incision, osteotomy, and apsectomy, thus reducing operative time, bone wear, and risk of assessing structures such as the maxillary sinus, in this way increasing the predictability of the procedure's success. Another breakthrough of great importance for endodontics was the advent of magnification using loupes or a microscope. Magnification and illumination allow the visibility of small points in the pulp chamber and in a greater extension of the vision in root canal. The use of apical locators also allowed for a more precise determination of the root canal length. This precise determination allows the cleaning and shaping of root canal along its entire length. Mechanized instrumentation allowed endodontic to work more quickly, and together with the advent of nickel-titanium alloys, allowed accessibility to regions with more extensive curvatures. Different files were performed by nickel-titanium alloys with different shapers, different cross-sections, and different heat treatments. In addition, different movements were introduced to endodontic treatments. Today, a range of rotatory, oscillatory, and reciprocrating systems are available on the market. In addition, biocompatible and bioactive materials have been developed for the endodontic arsenal. The development of mineral trioxide aggregate was a greater example of a material that, in addition to bring the concept of repairing material, served as the basis for the development of bioceramics used in endodontics. These materials interact with tissue, promoting tissue repair. And what is endodontics going? Endodontics is moving towards further advances in the knowledge of pathophysiology, therapy, and tissue regeneration, supported by knowledge of PULP and periradicular biology, and with the support of new tools for research in cell biology. Advances in the knowledge of pathophysiology allow a better understanding of the molecular pathways related to pulp and periradicular health disease. This knowledge can lead to the definitions of biomarkers that can be used to assess these states and monitor tissue repair in the future. In the context of therapy, endodontics has been increasingly involving its materials both in the development of new ones and in the improvement of the existing materials, making them increasingly biocompatible and bioactive, allowing tissue homeostasis and repair in a shorter period. A project related to material improvement is underway in our laboratory. In this project, 2 host defense peptides were added to the MTA extracts. Host defense peptides are biomolecules that have different biological functions, such as antimicrobial, immunomodulatory, and regenerative actions. In this work, we observed that the addition of DJK6 and IDR1018 peptides increased the antimicrobial action of MTA against Streptococcus mutans and did not alter the ability of MTA to stimulate proliferation and migration to close decellularized areas. This improvement favors repair when the MTA is used as a pulp capper and in pulpotomy. Another point that has been growing a lot of in terms of treatment is endodontic regenerative therapy. The basis of this treatment is in the understanding that in different places of the oral cavity, we can find mesenchymal stem cells, such as in gingival tissue, in periodontal ligament, in primary teeth, in immature permanent teeth, in dental follicles, in apical papilla, in bone alveolar, and in dental germ. It is already known that these different sources of mesenchymal stem cells, when isolated from the organism and stimulated in the laboratory, can differentiate in different cell types such as adipocytes, odontoblasts, and neural cells. This fact opens new possibilities of treatments and even business with the establishment of cell banks, cell therapies, and genome editing, which are already widely used as therapeutic forms in various diseases such as cancer, for example. Regenerative endodontic procedures were initially proposed for the treatment of necrotic immature permanent teeth. In the context of dental trauma, around 12 to 20% of children up to 12 years of age have already suffered some dental trauma. The fact is that at this age, several dental elements are into formation. When these elements erupt in the oral cavity, they undergo root formation and are thus called permanent immature teeth. These elements have thin roof walls and an open apex. Complete root formation occurs with the dentin deposition by odontoblasts residing in the dental pulp. Thus, when pulp necrosis occurs at this stage, the root formation is paralyzed. The dental element remains with thin roof walls and an open apex. For this clinical condition, regenerative endodontic procedures have become accepted protocols by American and European endodontic societies and involve a sequence of procedures that include coronary access, irrigation with antimicrobial solution, hypochlorite or chlorhexidine, and mild mechanical decontamination of the pulp space. Then, antibiotic pastes were used as intracanal medication, and after 3 to 4 weeks, in addition to remission of symptoms, the medication is removed and stimulation beyond the root apex is performed. This stimulation promotes the migration of mesenchymal stem cells from periradicular regions to the interior of root canal, together with the blood clot that starts to function as a scaffold for the formation of new tissue. Then, bioactive materials such as MTA or biodentin is accommodated in the cervical portion of the roof and the tooth is restored. The dental element is now monitored clinically and radiographically to verify the contamination of roof formation. For regenerative endodontic procedures to be successful, 3 pillars must be present: mesenchymal stem cells, scaffolds, and biomolecules. In addition, an environment with no infection is also necessary. In the endodontic scenario, stem cells are cells from periapical area. The scaffolds is represented by the blood clot, and biomolecules are represented by growth factors. All these pillars reach the root canal after instrumentation performed beyond the limits of the root canal. To achieve decontamination, in these cases, the chemical cleaning of the root canal must be well worked out since mechanical cleaning is compromised. Thus, the use of irrigant solutions and intracanal medication with antimicrobial action were recommended. The antibiotic pastes indicated for these situations are triple antibiotic paste composed of combination of minocycline, ciprofloxacin, and metronidazole, and the double antibiotic pastes with the removal of minocycline from this association. However, there are some criticism regarding these pastes involving dental staining using minocycline and dose-dependent toxicity. In addition, The use of these pastes confers only microbial action and does not have other important functions such as cell growth or cell differentiation. Thus, this field still deserves new development for the area. Host defense peptides are biomolecules that, in addition to have antimicrobial action, are immunomodulatory molecules and active in regenerative process. This is just an example of future research that involves improving these pastes. Studies from our group combined the antibiotic ciprofloxacin with the host defense IDR-1002. We observed that the association of this peptide with the antibiotic showed a synergistic antimicrobial action against Enterococcus faecalis and Staphylococcus aureus, allowing the reduction of the necessary concentration of both molecules to inhibit the growth of these microorganisms. We also observed that when this association was put in contact with PULP cells cultures stimulated in an environment with antigens and anti-inflammatory mediators, a decrease in the production of inflammatory and anti-inflammatory mediators occurred, promoting homeostasis. This response placed this association as a new possibility for intracanal medication for regenerative endodontic treatment. In regenerative endodontic therapy, another point that still deserves further research is the search for scaffolds. In this context, biological scaffolds prepared by tissue decellularization have already been carried on in different tissues, and 2 protocols have already been published for PULP tissue. Our research group reproduced these 2 protocols and observed that both allow the maintenance of the structure of PULP tissue observed by staining with hematoxylin and eosin and by scanning electron microscopy. In proteomic analysis, we also observed that this decellularized tissue managed to keep some of important proteins in the process of growth and tissue differentiation, showing potential scaffolds for regenerative endodontic process. However, thinking about biological scaffolds and large-scale use is something with several variables. Thus, our group has also been working on the development of synthetic scaffolds. In this sense, why not think about the development of scaffolds that contain antimicrobial components, growth factors, and that allow the adherence of stem cells? Our research group has been working on several synthetic scaffolds designed for controlled release of antimicrobials and growth factors. Scaffolds that allow cell adhesion and are resorbable as the new tissue forms. So, where we were heading for the development of a biological compound that stimulates tissue resorption. The idea is to expand the indication of PULP revascularization techniques not only for immature teeth, but also as therapy for mature permanent teeth. Thus, when we think about the past, present, and future of endodontics, a clear line of evolution is observed. And where is endodontic going? For a more personalized endodontics. The development of new technology must be accompanied by scientific knowledge and clinical practice. Only with these 2 fronts will we have significant development in endodontics. I would like to thank everyone who contributed to the results presented here. My work group at Catholic University of Brasilia, the universities that collaborated to obtain these results, and the financial support agents from Brazil. Thank you very much to the organization of Dental Summit for the invitation to speak on this subject that is of great interest to me. Thank you all. I put all my contacts in your disposal for questions and future collaborations. Thank you.